Very good afternoon to one and all. So basically this pediatric eye disease investigator group is a clinical network of pediatric optometrists and ophthalmologists which is funded by National Eye Institute, and they have conducted clinical research studies related to the pediatric eye conditions. Thus far majority of these pediatric studies have focused on evaluating the comparative effectiveness of different
your microphone is not coming.
Treatment for children and adolescents. So basically first study was refractive correction, that is ATS5, and aim was to evaluate effectiveness of refractive correction in moderate amblyopia, and they concluded amblyopia resolved in 27% of the patients and improvement of more than 2 line was seen in 77% patients with refractive correction only within 15 weeks of wearing of the glasses. So what is the clinical implication of this? The first line of therapy in amblyopia treatment is refractive correction alone for young children's. Optical treatment should be evaluated at a follow-up interval of 6 to 8 weeks until improvement in the amblyopic eye or visual acuity plateaus. Additional treatment with patching or atropine may be necessary if visual acuity improvement with spectacle alone is incomplete. Children who need additional amblyopia treatment after improved visual acuity from an optical treatment have better amblyopic eye visual acuity at the start of the next treatment phase, which can result in less treatment burden and better compliance. So some children may not need additional amblyopia treatment beyond optical correction. So ATS1 was whether to compare patching versus atropine penalization for treatment of moderate amblyopia in children of 3 to 7 years of age, and they concluded both are appropriate modality for initial treatment of moderate amblyopia. And they concluded atropine penalization is effective alternate therapy in treatment of amblyopia. Then ATS4 was daily atropine versus weekend atropine, and aim was to compare daily atropine versus weekend atropine in moderate amblyopia, and they concluded daily atropine and weekend atropine, they are equally effective. ATS8 was to compare weekend atropine augmented by plano lenses versus atropine alone in moderate amblyopia, and they concluded augmentation with weekend atropine does not improve visual acuity substantially. ATS9 was to compare patching with atropine in moderate amblyopia, and they concluded atropine and patching among older children with unilateral amblyopia does not improve. So what is the clinical implication of this atropine treatment? Atropine penalization has similar treatment effect as 2 and 6 hours of prescribed patching. Thus it can be considered as a first line amblyopia treatment or in some cases of the occlusion failure. Daily atropine administration is not necessary, and there is no reason to believe that atropine needs to be administered only on weekend days or days that needs to be sequential. And weekend atropine penalization has been shown to be effective in treating both moderate and severe amblyopia. Then ATS11 was to evaluate combined patching and atropine for residual amblyopia, and they concluded there is no additional benefit of combined treatment. And then this ATS13 was non-randomized prospective trial of glasses in strabismic alone and mixed amblyopia, and they concluded greater treatment effect in strabismic amblyopia can be with the combined mechanism amblyopia. So what are the drawbacks of ATS? Strict inclusion criteria hampered the study by including a limited number of patients. Methodology was not strict. Ethnic variation plays a role. And is atropine safe in tropical countries? And compliance was not objectively monitored. Then there is no shortcut or substitute for occlusion in amblyopia therapy. However, variability exists in number of hours prescribed to treat amblyopic patients. Then duration of patching in ATS2A full-time patching was compared with 6 hours patching in severe amblyopia, and they concluded similar improvement in both the groups. And in ATS2B, 2 hours patching was compared with 6 hours patching in moderate amblyopia, and they concluded similar improvement in both the groups. So it is to be noted that prescribing greater hours of patching did not seems to have significant beneficial effect in first 4 months of the treatment. So what is the clinical implication? Prior to Pedig trials, full-time occlusion was only commonly recommended in treatment of amblyopia. Full-time patching is not always required. Prescribing lesser amount of patching may promote better overall compliance with treatment. When patching is prescribed, it is reasonable to prescribe 2 hours of daily patching for moderate amblyopia and 6 hours of daily patching for severe amblyopia. Some children with severe amblyopia will respond to as little as 2 hours of patching, and in young children, using an adhesive patch should be strongly considered so that picking is less likely to occur. There is no consensus over duration of patching. Different authors have recommended different duration of patching. Then is there any age bar regarding treatment of amblyopia? ATS3 was conducted whether amblyopia can be successfully treated in older age children, and they concluded treatment can improve visual acuity in older children. Can amblyopia be corrected in adult patients? The answer is yes, because regardless of person's age, the visual system, which consists of eye, brain and visual pathway, can be retrained due to brain's plasticity, and the visual skill that needs to be retrained is binocular vision. Recurrence of amblyopia, majority of the children under 8 years of age, there is chances of recurrence, and therefore early follow-up is required. Patching doses should be gradually tapered rather than abruptly, and amblyopia recurrence is less common in older children, and parents should be counseled that approximately 20% of the children will have regression after amblyopia treatment suggestions. So, is there any role of near visual activities? Aim was to determine whether performing near visual activities while patching for amblyopia enhances improvement in visual acuity or not, and they concluded performing common near activities does not improve near visual outcome in treatment of amblyopia. However, there are a lot of other studies which are contrary to recommendation of the ATS6. Then ATS14 was pilot study of levodopa regarding the treatment of residual amblyopia, and they concluded that levodopa and carbidopa therapy is well tolerated in older children. However, there is article in ophthalmology recently which says that enough is enough, and these drugs, they are not effective in treatment of amblyopia. Then ATS18 was to compare effectiveness of 1 hour daily 1 hours per day of the binocular games per week with 2 hours of the games, 2 hours patching in treatment of amblyopia, and they concluded in children 3 to 5 years of age visual acuity improved with binocular gameplay and patching. Then ATS19 regarding excimer laser surgery for anisometropic amblyopia. This is ongoing study. Results have not been published. So, I would like to conclude that mainstay of treatment, the historical was patching, but now the current perspective is optical refractive correction, timing of refractive correction and occlusion. Earlier it was simultaneous, now it is sequential. Patching doses, initially it was full-time patching, now start with 2 hours and increase the dose if needed and start with 6 hours, and 2 hours is effective in some cases. It open penalization. Earlier it was only in patching failure cases, now it can be first line of treatment as an alternative to patching. And recurrence of amblyopia of treatment suggestion, there is highly likelihood of regression, and vast majority of the these amblyopic patients, they don't regress. Thank you.
Thank you, Dr. Subhash, for a very nice presentation. I think there are a lot. I think amblyopia is a very vast topic, and a lot of work has been done. And you have things like dioptrics. I think that part we have not covered in this talk.
Yes, sir.
And Dr. Santhan has another perspective. He has done a lot of work on his orthoptic. So, would you like to say something, Dr. Santhan?
Now, what happens in level 4C beta is the amount of glutamate released in amblyopia is reduced in amount, and it is of an inferior quality perhaps. So, unless you tackle this in the brain level, you can't do anything to amblyopia. Any amount of information you are sending up from the retina to the cortex will not cross the synapse where the blockage is. And if the information does not cross the synapse to go to inferotemporal cortex, where the analysis of vision happens, the vision will always be reduced. So therefore, all these dioptic binocs, the problem is they depend on sending more bottom-up impulses, whereas orthoptic depends on sending more top-down impulses. The top-down impulses cross the synapse and they bypass the suppression area in the synapse, and therefore they improve the vision.
Thank you, Dr. Santhan. Very nice. I think with time these things will be sorted out, and we are in that stage of limbo. I think with more work, more studies, we'll be having some clarity on this. Thank you, Roshan. Thank you. For the next talk,
Dr. Dadeya. Sorry for that.
she's having URL.
Are there any studies which is going on in dioptic? Pedig.
Yes.
Pedig.
Yeah, I have told this ATS18.
But video game, it
Yeah.
is just video game that is not working digress. But not Pinox, no. Not Pinox.
Video games.
Video games.
ATS18.
Dr. Deshpande is not here, otherwise he would have had another half an hour discussion on video games, you know. So he has two stalwarts, Dr. Santhan and Dr. Deshpande and Dr. Subhash.
Actually, we have done a study regarding use of television games, mobile games, video games.
Yes.
They are helpful and they improve the visual acuity.
Yeah.
We can
On-
play any type of game and we can improve.
Yes,
it.
yes, sir.
Actually,
Ordinary mobile games.
it does.
So,
Actually, a lot of commerce in it also, na, making all those games. Next.